Mm. Hello, welcome everyone. We're just gonna give everyone another minute. Okay, we're gonna get started. Hello, my name is Brianna Fonseca. I'm going to be introducing David Issacs. David Issacs is a Master of Public Health, Doctor of Medicine, obtained his Bachelor of Science from the University of Southern Indiana, his medical degree from Indiana University School of Medicine, and his Master of Public Health from Vanderbilt University. He completed his neurology residency and movement disorder fellowship at Vanderbilt University of Medical Health Center. Clinically, Dr. Issacs served children, adolescents, and adults with TIC disorders, and is co-director of the Vanderbilt Center of Tourette Syndrome and Other TIC Disorders, a Tourette Association of America Center of Excellence. His research focuses on sensory function in Tourette syndrome, assesses via self-report questionnaires and neurophysiologic I can't pronounce that. Sorry, I can't pronounce any of this. Can you help me out with that? Sorry.
Yeah. Neurophysiologic. Yeah. EEG. Yeah.
Yes. Sorry.
That's okay.
Sociologic factors influencing the clinic course of Tourette syndrome and quality of life across the lifespan of individuals with Tourette syndrome. Dr. Issacs receives funding from the Tourette Association of America, Teva Pharmaceuticals, and the National Institute of Neurological Disorders and Stroke. Welcome. Sorry about it.
No worries. Yeah, thank you for the introduction, Brianna. I appreciate it.
I tried my best.
Yeah, no, that's fine. Good morning, everyone, and thanks to the Tourette Association for allowing me to present to you all this morning. And I'm going to, in the next 30 minutes, provide a little bit of background and an overview of some of the work that we've been doing here at our center, investigating the impact of environmental stressors on adults with Tourette syndrome. And so this is just a brief outline of what we'll talk about in the next 30 minutes. I'll first just give a few slides talking about the adult Tourette syndrome phenotype, and then we'll actually talk for a couple of slides about the impact of environmental stress on long-term health in individuals without Tourette syndrome, so just kind of speaking more generally, and then we'll return to how that impacts adults with Tourette syndrome specifically. And so that we'll jump right in. I'll say it. I should also say, if people have questions, please feel free to enter those in the Q&A. And as time allows, at the end, I'll be happy to address those. And if there are other discussion points, you're welcome to put that in the chat. So everyone here knows that Tourette syndrome is defined by the presence of tics with childhood onset, and the tics persist for more than a year. And on the left here is a fairly classic figure showing the typical trajectory of tics in the setting of Tourette syndrome, with an onset roughly between 4 and 8 years of age. For many people, there's a gradual increase in the severity of the tics during late childhood and early adolescence, with often a peak in the severity in early adolescence. And then a substantial percentage of individuals, their tics will gradually improve as they move throughout adolescence. And because of this trend, historically, that there's been perhaps a trend to consider the impact of Tourette syndrome to be confined to childhood and adolescence, that once people passed through this peak, that they had really kind of passed through the worst of Tourette syndrome. But recent evidence has shown that, in fact, tics continue to affect people long term. And so we know, for example, this is a nice review article by Reagan et al. From last year, that the majority of individuals with Tourette syndrome continue to experience tics into adulthood. As many as 80 or 90% still exhibit tics as adults. 1/3 of individuals with Tourette syndrome are still negatively impacted by their tics. They continue to bother them. And a similar percentage reported avoiding social situations because of tics in the impact survey that was conducted now 10 years ago. And so this evidence suggests that, in fact, tics themselves do continue to affect affect life, affect people even as they age into adulthood. And when we think about Tourette syndrome more broadly and think about the co-occurring psychiatric conditions that are very prevalent in this population, then we have even more cause for concern about the adulthood experience of Tourette syndrome. So on the left here, this is a figure from the Tourette Association. I'm sure that most of you are familiar with. And what we see is that the tics are represented on the top of the iceberg, and then below the water are various co-occurring psychiatric conditions. And we know from various studies that 90% of individuals with Tourette syndrome have at least one of these co-occurring conditions, and about 60% or so have two or more. And so really it is the norm to have at least one or several of these co-occurring conditions. And while many of these may first manifest in childhood and adolescence, we certainly see persistence of these disorders and or symptoms into adulthood. And so this study by Hirsch et al. That was from the JAMA Psychiatry now several years ago found that the lifetime prevalence rates of multiple different psychiatric diagnoses was elevated in adults with Tourette syndrome. And so there was a lifetime prevalence of mood disorders around 60%, anxiety disorders 40%, OCD 55%, and ADHD 36%. And so while we know that some of these would have been diagnosed in childhood, and so this lifetime sort of encompasses that, both childhood, adolescent, and adulthood diagnoses, it's certainly true that many individuals who are diagnosed in childhood with these co-occurring conditions may still manifest these symptoms as adults, may still meet diagnostic criteria for these conditions as adults, and may even develop new psychiatric conditions as adults. And so the psychiatric facets of Tourette syndrome continue to affect even adults with Tourette syndrome. And then thinking beyond even psychiatric diagnoses, there's a small amount of literature looking at the social impact of adults with Tourette syndrome. And as many as 1/3 of adults with Tourette syndrome note that they feel like they're inadequately supported by their families. And we saw on the prior slide that a lot of adults will avoid social situations. That was due to tics, but certainly due to other of these psychiatric co-occurring conditions. So there are social ramifications for adults with Tourette syndrome as well. And then additionally, in the last 8 or 9 years, there's been increasing evidence of the physical health toll of having a diagnosis of Tourette syndrome. And so what I have cited here on these different bullets are studies that have been published in the last 8 or 9 years talking about just this. So we know relative to the general population that there is a 4-fold greater odds of completing suicide in individuals with Tourette syndrome. There's a 2.5 higher risk of substance-related death, a nearly 3-fold higher risk of obesity, and a nearly 2-fold higher risk of type 2 diabetes, and a similar higher risk of cardiovascular disease. This figure on the right shows the cumulative incidence of cardiometabolic disorders. And the top line here, it's red and has the orange coloring around it, represents individuals with Tourette syndrome or another chronic tic disorder. And then this bottom line here are those who are not affected by Tourette syndrome. And what you can see is that these curves start to separate in early adolescence, and that the incidence gap, the difference between the two groups of individuals, widens with age. And so even beyond kind of thinking about the traditional core symptoms of Tourette syndrome with tics and psychiatric co-occurring conditions, there's now this additional facet of the physical health toll, which we know is actually the case for many neuropsychiatric disorders, that there is a physical health toll associated with those diagnoses. And most strikingly, this paper from Meyer et al. That was published in Movement Disorders now about 5 years ago found that there was a nearly twofold higher risk of premature death from any cause in people diagnosed with Tourette syndrome or other tic disorders. Because we know that there is a high association of comorbid, co-occurring psychiatric conditions with Tourette syndrome, one might reasonably speculate that perhaps this higher risk of premature death is due to those other conditions. And Meyer et al. Did a nice job. They conducted some sensitivity analyses. And even after you exclude individuals who have comorbid ADHD, OCD, and substance use, the tics remain significantly associated with a higher mortality rate. And so this tells us there's definitely more going on here than perhaps what we have traditionally considered, again, when we just limit ourselves to thinking about tics themselves. And so a question, that when I'm in clinic and then also in our group has been, when we see an adolescent or a child with Tourette syndrome who presents with multiple manifestations, obviously tics, as well as perhaps ADHD, anxiety, different disruptive behaviors. The question for me is, obviously we want to address these here and now as much as possible, but also what is the long-term course of that individual? All of the evidence I've just shown you says that there definitely is an ongoing lifespan impact from having Tourette syndrome. And so what does that look like, not only when you're 12, but when you're 42? And we know that tics themselves evolve over the course of development. And so perhaps vocal tics may resolve. There may be some persistent motor tics, which may or may not be bothersome or disruptive for the individual. We may see persistent anxiety that was present earlier, but perhaps now the individual is struggling with depression episodically, or sleep issues, or diabetes. So I think, really the question has been not only how can we help individuals with Tourette syndrome address their tics and how that impacts their quality of life and their long-term functioning, but how can we help their quality of life and functioning more generally, kind of thinking about this very broadly. And why that's important is ultimately because we know that adults with Tourette syndrome have poor quality of life as a group. And in fact, their quality of life is worse, at least in one study found, is worse than adults with other chronic illnesses and even adults with terminal cancer. And so there's clearly a gap here that we need to fill or try to address for this group of vulnerable individuals. So I'm going to pause here talking about Tourette syndrome and shift slightly to talk about environmental stressors and their impact on long-term health in individuals without Tourette syndrome. And then we'll turn back to look at how that impacts or how that might be linked with Tourette syndrome specifically. Many of you are probably familiar with ACEs, which are adverse childhood experiences. And these are stressful or traumatic events that children experience. The seminal work was done out of a Kaiser Permanente study now over 20 years ago. And in that study, they had looked at 10 different ACEs, and they were grouped into 3 different categories of abuse, neglect, and household instability. And what was remarkable about this study and subsequent work that has been done over the past 2 decades is that these different childhood experiences, these ACEs, have been linked with a innumerable variety of adult health outcomes spanning mental health and physical health. And what I've listed here this is a very small sample of the different types of conditions or symptoms or diagnoses that have been linked with ACEs. So you can see here traumatic injuries, depression, anxiety, suicide, PTSD, sexually transmitted infections, diabetes, poverty, HIV, cancer, literally across the board. What we see is that there is a link between these ACEs and these later adult outcomes. And the reason that this is particularly important is because ACEs are common. As many as 2/3 of the US population has been exposed to at least one ACE. And many have been exposed to multiple ACEs. And we also know that seems to be a dose-response relationship. And so the more ACEs one experiences or one has been exposed to, the higher the risk of multiple adult health outcomes, negative adult health outcomes. The means by which this happens is not clear, but there's definitely been an explosion of work in this area. And so I'm not going to go through this schematic in great detail. This is a really nice review article. Now it's 10 years old, but still very pertinent. But I just wanted to highlight a few pieces of this figure. So the first is that you can see up here are different early life social environmental factors. And here you can see trauma. And we know that these different factors influence different parts of the bodily functioning, so the immune function, neuroendocrine stress response, and critically brain development, and that the effect of these different factors on these different aspects of our health then lead to long-term changes that ultimately result in a variety of adult health and developmental outcomes. And so I wanted to stress not only that there are some various biological mechanisms, and it's probably multifold, that are implicated in this process, but also that there are potential protective risk factors or mitigating factors. So, for example, having support from a caring adult, having a positive family functioning, that there is evidence that these positive childhood experiences can reduce the risk or lessen the association of ACEs with these adult health outcomes. And so, again, this is a very complex area that's still definitely, there's a lot of work to be done that is being done. And it's exciting because we think that a lot of these points may be areas of intervention to improve health. And so what ultimately does this have to do with Tourette syndrome? On this slide, I had actually bolded a few of these items that are known to be to occur more frequently in people who've been exposed to ACEs. These bolded items are ones that are more prevalent in adults with Tourette syndrome. And so the natural question is, could ACEs, as well as other environmental stressors, have any effect or influence the trajectory of adults with Tourette syndrome, the clinical trajectory? And so individuals who have more ACEs or other types of environmental stressors, could that lead to overall worse outcomes as adults? And there have been a few groups that have actually looked at this and explored this question. There was a nice study and paper that was published last year out of the group at MGH looking at adults with Tourette syndrome. And what they found was that ACEs were linked with the worst ever TIC severity and impairment as measured by the YTTSS, the Yale Global TIC Severity Scale. And so they did find that association there. An older study had looked actually at children and adolescents, and they found that baseline environmental stress predicted TIC severity and psychiatric symptom severity 2 years later. And so there has been some initial work examining this question, but there's still a lot that's unclear in terms of what is the longitudinal impact of stressors on adults. And the reason this is important, as I alluded to a second ago, is that not only may this enhance our ability to prognose for patients and their families, but ultimately what we would hope is that if we could identify modifiable risk factors, then that can help us hopefully improve not only the severity of tics and mental health symptoms as adults, but also physical health problems and quality of life. And so, so this has potentially wide-ranging ramifications for not only adults with Tourette syndrome, but also children and adolescents who obviously will become adults. And so how can we improve the life of all of these individuals? And so our group has been interested in this question, and I've restated the question up here, trying to be more succinct, which is what is the impact of environmental stressors on the long-term outcomes in adults with Tourette syndrome? And I've been talking primarily about ACEs the last few slides, but for the purposes of our study, we've actually are looking more broadly at environmental stressors. And here we've defined that as an external condition or event that poses a threat to someone's well-being. And so we've designed this study, and I've just given some highlights here, but we are assessing clinical symptoms, quality of life, and cumulative stress burden in adults with Tourette syndrome. And the plan is to do this prospectively every 2 years. The study we just received IRB approval a little over a year ago. So right now I'm going to show some preliminary baseline data. We obviously don't have any longitudinal data just yet. We're primarily recruiting through our adult Tourette syndrome clinic. And I've listed here the different measures that we're collecting. So obviously various socio and demographic variables. We have some indices or metrics looking at ADHD and OCD, depression, anxiety, as well as things like perceived social support, quality of life. And then I've bolded here the different measures that we're using to try to quantify environmental stressors. This is a measure that looks at ACEs, both the original 10 ACEs, but as well as some additional ACEs that have subsequently come to light. So, for example, the safety of your neighborhood and your community, how safe do you feel? So it's a little bit a broader definition of ACE. We're using the strain, which I'll touch on in just a second at the next slide. And then we are looking at positive childhood experiences. So what are these different, perhaps protective or mitigating factors? So we're trying to examine that as well. And then using a couple of clinician-administered measures like the YGTSS and then a structured neuropsychiatric interview. I'm going to briefly touch on the strain, which is the stress and adversity inventory. And this is a measure we're using in collaboration with George Slavich and his group out of UCLA. It is an NIMH, the National Institute of Mental Health, recommended assessment tool. And there is a self-administered version, which is what we're using. And basically, it asks participants, individuals, to if they have experienced a variety of not only acute life events, but also chronic difficulties. And so these may be different environmental stressors that aren't ACEs per se, but are still thought to be potentially traumatic in the sense of having, bullying or being repeatedly exposed to different negative life experiences. It also looks at these not only in child and adolescents, but also as adults. It is a lifetime assessment tool, at least the version we're using, and it gives some insight into a variety of different domains. And so what's listed here on this table in this column under primary life domain are the different types of stressors that are looked at, that are examined by this tool. And it generates a variety of indices that give some sense of both acute stressors, both in terms of the number of them and also their perceived impact, as well as chronic. And I think that's an important facet of this work, is we want to really understand, do these affect a person differentially? And so in the next few minutes, I'm just going to give some preliminary results. And I will emphasize again, this is very preliminary. We've so far recruited 38 participants. Our sample, this is just some of the basic demographics, is unfortunately not very diverse. It's largely a non-Hispanic white population, which certainly is a limitation of this work. In terms of the number of co-occurring conditions, it's perhaps what you would expect. In terms of a large percentage have ADHD and OCD, about half have anxiety disorders that have been previously diagnosed, and a third or so have a previous diagnosis of a mood disorder. For the sake of time, I'm actually going to move beyond, and I really want to focus on the environmental stressors. And so you can see from our sample that in terms of just the number of ACEs, and these are the original 10, it really corresponds or matches well with the general U.S. population. A little under a third of adults in our sample had denied any ACEs in childhood. But then on the flip side, as many as a third had 3 or more. And so there does seem to be, certainly a continuum of the number of ACEs that people are experiencing. And I'm going to come back to that table in just a second. And this is a histogram showing the counts of the different types of ACEs that of the participants in our study. And what you can see here, I'll draw your attention, is that this large blue bar on the left represents emotional abuse, which was the most frequently endorsed ACE. And then the second most common was having living with a family member with a mental health diagnosis. And certainly given the strong genetic pattern that we see in Tourette syndrome, it's not surprising. Obviously, a lot of the parents and family members of these individuals would also be affected by various psychiatric diagnoses. And so that's not surprising, but it's interesting nonetheless. And our findings so far, and again, in our small sample, replicate the results from the group that published last year from out of MGH, where they also found that mental illness in the household and emotional abuse were the two most prevalent ACEs in their sample. So coming back to this table, I want to now draw your attention to the bottom 2/3. And these are different indices or metrics, scores that are generated by the strain. And obviously, for sake of time, I can't go through all of these, but I just wanted to give a sense of kind of the granularity of the different data that we're collecting, and some of these different, both in terms of looking at early adversity, adult adversity, and then even kind of breaking it down further into looking at just in the past year, so kind of more recent stressors. And so it gives you not only a sense of the types of stressors, but also the timeline over the course of someone's life at which these different stressors may have happened. And as I mentioned when I was talking about the strain, it also provides data on the different types or categories of environmental stressors. And this is data from our study. And so what you can see is in terms of the different domains of stress in which people reported, that the two that were most commonly affected, or the two most stressful areas, would have been non-marital, non-partner relationships, and then perhaps not unsurprisingly, treatment and health. And so I just kind of, again, want to kind of show some of the variety of the data that is coming out of this and what we hope to explore further. In the last couple of slides, because I realize we're getting close on time, I wanted to show, first that the strain output does correlate with ACEs, which is, what you would expect. But you can see here that a number of people who had no ACEs still had relatively high scores on the strain. And so what that tells us is that, again, there's just more granularity, that there may be chronic or acute stressors that don't meet the criteria for an ACE, but could still contribute negatively to someone's adult outcomes. And that increased granularity provided by the strain may allow for deeper insights in terms of the connection between environmental stress and different adult outcomes. On the left here is a scatter plot of ACEs score versus the Yale Global TIC Severity Score, YGTSS, and you can see there's no strong correlation between those two measures. But with the strain, there is a significant correlation with the total TIC severity score, relatively robust. And we see a similar phenomenon for a health-related quality of life measure, the GTS score, where there is a strong relationship between strain output and the adult quality of life, and a much weaker and not statistically significant association with ACEs and the adult quality of life measure. So certainly our work has some important limitations. Like most studies of ACEs, we are relying on recollection. So there's certainly the potential for bias there. We're hoping to partially mitigate that by collecting prospective data. So this is a longitudinally designed study. As I mentioned earlier, the sample is not diverse, which again is something we're hoping to work on and improve the diversity of our sample. We are primarily recruiting at this time through our clinic. So it tends to be adults who are more severely affected by tics and other psychiatric diagnoses. And so that, kind of the generalizability is a concern here. And then ultimately, we really like to be collecting additional measures. Again, I talked about the relationship between environmental stress and physical health. And so as the study is currently designed, we are not looking at physical health, things like blood pressure, BMI, heart rate, these kinds of output. And looking at things like resiliency. These are kind of areas of future direction. And ultimately, this is work that we would love to collaborate with other sites or other groups who might be interested in looking at something similar. And I certainly welcome any questions or feedback about the work we're doing. And I put my email here, and it's in the slide deck. So please feel free to contact me with any questions or concerns about this study. And again, the ultimate hope is to not only identify relationships between environmental stress and these adult outcomes, but really to then intervene. That's the ultimate goal, is to improve the quality of life and the overall health of our patients and those living with Tourette syndrome. And with that, I'll conclude. I just have a lot of people to thank. Certainly, again, the Tourette Association, NINDS for funding some of this work, and then we have a wonderful team that would be impossible to do this without them. And I'd definitely like to thank the patients and participants who really made this work possible. And so I realize we're running right up against time here, but I'm happy to take a few questions. So I'm going to pull that up here now. And again, people are welcome to email me questions or directly email me. That's certainly fine. One person in the chat asked, said, I grew out of my tics in my late teens and early 20s. Then they came back in my 40s. How normal is this? Yeah, I'd say there's definitely a big gap in our knowledge in terms of the course of tics in adulthood. I have seen other individuals in my clinic who've had similar phenomena where maybe they had tics earlier, tics, improved or even resolved for a period of time, and then later in life came back. So you're not alone. I have certainly had other patients who had that experience. It's hard to comment how common that is because again, we don't have enough evidence or data on adults, which is again an area that we're trying to address. Do you know the comorbidity of tics and bipolar 1 disorder? I do know that the prevalence of bipolar disorder is increased in the Tourette syndrome and chronic tic disorder population. Off the top of my head, I cannot give a specific number, but I know that it's higher than in the general population. So I apologize, I can't be more specific than that. And then there's a question that says, could you go into more detail about how individuals with TS are at higher risk of diabetes and cardiovascular disease? I would really refer you. There are two papers. One is in JAMA Neurology, and that is by Brander et al. From 2019. And it used a large European national registry and looked at number of diagnostic codes for cardiovascular disease and metabolic disorders, and in individuals with Tourette syndrome and other tic disorders. And so that was really a kind of a large study that found this association. And then the study by Meyer et al. From 2017, which was in movement disorders, I believe, Journal of Movement Disorders, is the one that talked about premature death. And if you would like the specific references, I'm happy to share those. Just feel free to email me, and I'll happy to send you those references. There was a question about, which is a good one, about the increased risk for obesity, diabetes, and cardiovascular disease, and whether those associations still persisted after controlling for medication use. I can comment. So on the study by Meyer et al., where that's the one that found about the premature death. Very interestingly, they actually found that when they did control for, in a sensitivity analysis, they controlled for the use of antipsychotic medications, which are known to be associated with increased risk of cardiovascular metabolic disease. Interestingly, and very difficult to explain, people who were treated with antipsychotic medications had a lower risk of premature death and lower risks of some of these other outcomes. And so, which is very counterintuitive, and the authors actually acknowledge that. So it seems, again, I think it's an excellent question, and I think I would say the answer is still unclear, but certainly an important question. There is a question that says, if co-occurring conditions are so common in individuals with TS, why are these traits not added in the DSM as additional criteria? TS is definitely more than just tics. And I think that's an excellent question. I think that really goes to the root of kind of how we diagnose mental health and other neuropsychiatric disorders. And I think there's definitely been a shift from thinking about things in terms of we call categorically. So you have or do not have this diagnosis. There's certainly been a shift through the NIMH and through lots of other organizations to thinking about mental health and other neuropsychiatric symptoms on a continuum we call dimensionally. So that's probably a broader discussion than what I can answer here in these few minutes, but I think it's an excellent question and a good point. Tom asks, by every 2 years, is this repeating the study every 2 years, or is it a biannual follow-up with the same study group? Good question. The plan is to actually repeat this assessment every 2 years. So someone does the assessment, and then 2 years later they do it again. And then the hope would be to continue doing this every 2 years so we develop longitudinal data. And then there's a question about where you can see the slides, and I believe those are actually accessible where you click to join the meeting. At the bottom, I think there's a way to access the slide deck. You're also welcome to email me, and I'm happy to send you the slides. And then someone wanted to see my email address again, which I'll put that right there while I'm looking at these. Do you have any recommended pages or books for children with TS, anxiety, ADHD, and sensory modulation disorders? That's a good question. There are many excellent resources there. I know the Tourette Association has some on their website, www.tourette.org. And we have some that we typically recommend in our own clinics. And again, maybe it might be easiest if you just email me. I'd be happy to share that list that we share. But yeah, there's a lot of really good resources for that. There's a question about functional tics. I may defer that question for now. I believe there's some talks on that later, and it's a little bit beyond the scope of kind of the topic that we've been talking here. So I apologize, but I may defer that question. And then the last question in the Q&A is, if I started having tics when taking antidepressants and then antipsychotics and was called tardive dyskinesia and stopped the medication and they continued, is it now Tourette's? That is a very good question. In the Diagnostic Statistics Manual, the DSM, which is what we use when we look at the criteria to diagnose Tourette syndrome, there are several criteria. So presence of motor and phonic tics with onset before age 18, persistence of those tics in some capacity for a year. And then at the bottom, there's always this criterion that says there's not another better explanation. And so, for example, some individuals with things like Huntington's disease may have tics, but if it becomes clear they do have Huntington's disease and they have other symptoms, we wouldn't diagnose that person with Tourette syndrome. We would say they have Huntington's disease and they happen to have tics as part of that. It gets complicated with medications. And so it really at that point becomes up to kind of I'd say the perspective or the judgment of the clinician. And so there's certainly some gray areas. But if someone felt like those tics would have been present regardless, then they might diagnose with Tourette syndrome, especially if there's a presence of co-occurring conditions that are very common with Tourette syndrome. So OCD and ADHD, which, for example, were not likely to be medication induced. If those weren't present and it really was just the tics and there were these exposures, then it becomes a lot more challenging. And so there could be some debate. So that's certainly a great question and one I can't definitively answer, but it's a good question.
That's time.
Sure. I realize I've gone over. So
Thank you so much.
Thanks, Brianna.
I have left a survey in the chat. If everyone can just please take a second to fill out the survey. Please visit our TIC-CON lounge for TAA resources, as well as the various information booths, and continue to join the TAA virtual conference.
Thank you all.